Who am I? Clue number one. I am in thrombohemorrhagic disorder. Usually disorders would be either hemorrhagic or thrombus forming. I can do both. I can be forming small thrombi, also in blood vessels I can cause severe hemorrhage. Clue number two, I am never a primary disorder. I always occur due to something else, some other disorders. Clue number three, the typical diagnostic profile of me would be like this, something like this. Low platelet count, low fibrinogen level, prolonged prothrombin time, PT, prolonged activated partial thromboplastin time, APTT, prolonged thrombin time, TT, and elevated D-dimer level and fibrin degradation products. Clue number four is that I am also typically associated with MAHA, microangiopathic hemolytic anemia, and you can see presence of cystocytes on peripheral blood smear due to me. And clue number five is this, that I can be associated with many things, like let's say I can be associated with sepsis, I can be associated with snake bites, I can associate with trauma, I can be associated with burn injury, thermal injury, I can be associated with obstetric complications, childbirth related complications like intrauterine fetal death, septic abortion, placenta, abruptio placentae, placenta previa, eclampsia, all these kind of things, and also amniotic fluid embolism. I could be associated with cancers also, cancers like acute promyelocytic leukemia, previously called M3ML. I could be associated with some mucin secreting adenocarcinomas also, like arising from the pancreas or the stomach. Now, after these five clues, I think it's very easy for you to figure it out. Who am I? I am basically DIC, disseminated intravascular coagulation. And as the name implies, the disease is that the term is coined because the disease usually shows presence of small thrombi, that means blood clots, in the small blood vessels. Disseminated means widespread, intravascular means within the blood vessel, and coagulation means clot formation. So what is happening? Something which is another disorder is triggering an abnormal activation of the clotting pathway or coagulation pathway or the hemostatic pathways in a person. That something could be all those things which I mentioned, which sometimes you can remember by a term called stop making DIC. S for sepsis, T for a snake bite also, T for trauma like burn injury, like thermal injury, O for obstetric complications, all these things I mentioned, amniotic fluid embolism, abruptio placentae, septic abortion, intrauterine fetal demise, all this. And P for pancreatitis, acute pancreatitis typically, and M for malignancies. So stop STOP, makings MEM, M, and DIC is D. DIC is basically that this is acronyms for DIC. Now what's the problem here? That all these things, they're leading to the development of DIC. And all these things, they're either releasing some procoagulants, that means which supports coagulative pathway, and also contributing by endothelial injury, and thereby somehow they're activating the coagulation pathways, clotting pathways in an abnormal way. Normally our hemostatic pathways, coagulation pathways only get activated when we need them. When do we need them? We need them when we are bleeding. So we need to stop that bleeding to form a clot formation. But in DIC, that thing is happening without any necessity, without any reason, inappropriately. There is an aberrant generalized activation of the clotting pathways. And as a result, what is happening? There are many things happening. One thing is happening that platelets and coagulation factors are getting consumed unnecessarily to make the blood clots. And as a result, their levels are getting decreased, which can contribute to bleeding. And as these blood clots are made in small blood vessels, they can cause tissue infarction and related changes in the organ. This thrombus formation, they can cause a lot of changes or damages in the kidney, in the lung, in the adrenal and other places. Syndromes like Waterhouse-Friderichsen syndrome can be associated with this. It could lead to acute kidney injury also. So one side is that there is a small microthrombi is forming in the blood vessel, which can cause this infarction-related changes in many organs. One side is also that as these small blood clots are made, they consume, while making these blood clots, these platelets and clotting factors get consumed, and that can decrease these clotting factors and platelet. As a result, you can develop the bleeding. Another thing is happening when these small blood clots are made inside a small blood vessel. A RBC can come at a high speed and hit them and can be hemolyzed. This can lead to a form of extrinsic or extracorpuscular form of hemolytic anemia, which is called microangiopathic hemolytic anemia, because the hemolysis is occurring in a small blood vessel. Why in a small blood vessel? Because a small blood vessel has already a narrow lumen, and that narrow lumen can be further narrowed by formation of that clot which is happening. So when that RBC, which is coming at a high speed, they hit that blood clot, it will be lysed and could result in the formation of hemolysis and ruptured RBC, a form of hemolytic anemia which is called microangiopathic hemolytic anemia. So this is one of the things which shows the clue number 3 there. And as a result of microangiopathic hemolytic anemia, you can get fragmented red blood cells or cystocytes on the peripheral blood. Now another thing steps in, that as these blood clots are forming, normally physiologically in our body, there's also another pathway to lyse these clots, because otherwise clots would increase forever and occlude the blood vessel. But that never happens, because whenever a blood clot forms and stops the bleeding, that blood clot next, when its job is done, would be lysed by a fibrinolytic pathway. That fibrinolytic pathway is controlled by the plasminogen, which can be activated by tissue plasminogen activator. And ultimately plasminogen, which is an inactive substance, which is normally roaming around the blood, which has a blood clot lysis capacity, but usually remains inactivated state, they would be converted from plasminogen, because it causes genesis of plasmine. So plasminogen would be converted into plasmine. That plasmine would now start to act on all these clots. This fibrinolytic pathway would be activated. And as these clots are mostly made of fibrin, fibrin platelet, because as a result of abnormal activation of the coagulation pathway, these small blood clots are made. These fibrin clots would be degraded into fibrin degradation products, including D-dimer. So their level would be elevated. And that's why in the diagnostic what I was getting, that as the fibrin degradation product D-dimer's level would be elevated, as during the process of this abnormal clot formation, unnecessary clot formation, the platelets got consumed, fibrinogen, which is the clotting factor 1, that got consumed, all the clotting factors, including intrinsic pathway and extrinsic pathway, everything got consumed. So as the intrinsic pathway factors got consumed, their level is low, APTT would be prolonged. As extrinsic pathway factors get consumed, that's why prothrombin time, PT level would be elevated. As fibrinogen level is low, fibrinogen is low because fibrinogen is used up, so fibrinogen level would be low. And due to the low fibrinogen and prothrombin, thrombin time would also be elevated, because thrombin time basically checks the last step in the coagulation pathway, fibrinogen to fibrin. So platelet would be low, fibrinogen would be low. All these times, prothrombin time, activated partial thromboplastin time, thrombin time would be prolonged. And D-dimer, including which is the type of FDP, fibrin degradation product, their level would be elevated. So these are the diagnostic findings. And as I mentioned, is that this is always an acquired thrombohemorrhagic disorder. This is not an inherited disorder. This is an acquired thrombohemorrhagic disorder, because DIC can present with a thrombus and DIC can present with severe hemorrhage also. Like it can present in a patient who was admitted in the ICU with sudden bleeding from the intravenous sites of the catheter and other places. So that's why this is a paradoxical condition which can present with both thrombus and hemorrhage. It is called acquired thrombohemorrhagic disorder. Another thing which I already mentioned, it is never a primary disorder. It's always occurs due to something else. So obviously the root way to manage it, the key way to manage it would be to manage the root cause which is causing those things, like those cancer, sepsis, infections or other things. So that's all the key things about TIC. Thank you so much.